నేను Dr.Shakuntala Ghosh, Senior Consultant ENT and Director, Rama ENT Care Center, Hyderabad.
About a case of bilateral otosclerosis in a 25-year-old boy and presenting with about moderate conductive hearing loss. As you can see the audiogram, and this is how I do it. I do endoscopic stapedotomy on the left side. So using a 0-degree nasal endoscope, I am making the canal incisions, radial incisions at 6 o'clock and 12 o'clock positions using the Piston knife. So I am joining both the incisions with a horizontal incision at the mucocutaneous junction in order to raise the posterior based tympanomeatal flap. So about 6 to 8 millimeter in size, that is the length of the flap raised. So in otosclerosis cases, we have to be careful that we raise the adequate flap, because after curating of the bone in the posterior superior region, we may not have adequate flap to cover the defect if we don't raise a wide enough flap. So here, as you can see, I've raised the flap completely and reached the annulus, and now I'm trying to elevate the fibrous annulus with the help of a periosteum elevator. And one should take care not to cause any tear of the flap at this junction. So one should be extremely patient and careful. Using a sharp curved pick, I am dissecting off the fibrous annulus from the bony annulus, and then using the forceps, the alligator forceps, I am gently teasing off the mucocutaneous flap of the bone and reflecting it anteriorly onto the anterior canal wall. So the first important thing here is, so after raising the flap there will be some bleeding, so we can use adrenaline soaked cottonoids for hemostasis. Once we keep it for 5 minutes, the bleeding will stop. Next, after exposing the posterior superior bony canal area, I am using the curette to curette the bone in order to visualize the IS joint. Here you can see the chorda also. I am gently elevating it off along with the flap in order to expose the incus long process, the stapes. So enough curettage has to be done from the notch of ravenous superiorly up to the area of the pyramidal eminence where the stapedial tendon arises. So that area, that quadrant has to be visible clearly in order to do a good stapedotomy. So the curating direction should be from above downwards and from medial to lateral in order to avoid injury to the ossicles. Next, I am seeing the stapes foot plate. I have palpated the ossicles to see that the incus is mobile and the malleus is mobile, whereas the stapes is fixed. Now using a 0.4 mm straight pick, I am making a control fenestrum in the foot plate with gentle rotatory movements till I find I actually feel a give and the pick goes in and the patient complains of mild vertigo. So that is an indication that I have made a fenestrum and I have entered the vestibule. So there will be a gentle give. Care is taken not to injure the suprastructure here. So mine is a reverse stapedotomy technique. So I make the control fenestrum, after which I remove the stapes suprastructure. So this prevents accidental mobilization of the foot plate and I have good control. As you can see, I have made the fenestrum which is 0.4 diameter in size. Now I will widen it with a burr to make it a 0.5 mm diameter fenestrum. That is the fenestrum you can see in the foot plate with a little perilymph leak. Next, I do a stapedotomy using a curved pick and then the scissors, the fine micro scissors, I have cut the stapedial tendon which is arising from the pyramidal process. That's it. Next, I try to dislocate the IS joint and separate the Stapes suprastructure. So I try to identify the IS joint, and using a sharp curved pick, I make a cut and separate the Stapes gently. One has to be extremely gentle at this step to avoid inadvertent dislocation of the entire foot plate. That is subluxation of the entire foot plate along with the suprastructure. So as you can see that there is some fibrous band between the incus lenticular process and the Stapes head, which I am trying to dissect and separate the Stapes head completely. I am pushing it downwards, and next after separation I am using an alligator forceps to remove the entire Stapes suprastructure. So this is the posterior crura and the anterior crura. And now you can see the fenestrum very well. At this point, I take a dry gel foam to mop up any blood which is present. We are not supposed to do direct suction on the fenestrum once we have opened the vestibule. That can lead to sensory neural loss. We can do suction all around but not directly on the fenestrum. So a dry gel foam piece can be used to suck out any excess blood, and suction can be done on the gel foam. So I am trying to widen the fenestrum to make it a 0.5 mm diameter wide fenestrum in the posterior part of the foot plate. Next, I take a piston, Teflon piston, which is 0.4 mm diameter, and here I have measured and the length is 4.5 millimeter, and I have measured it, and now I am trying to insert it with the help of the alligator. So I have inserted into the foot plate fenestrum, and now gently I try to push it onto the long process of the incus so that it fits snugly there. We have seen that. Now we can see both the ends, the deeper end, the medial end into the fenestrum, and the lateral end which is hooked around the long process. Next is crimping. So I have crimped the hook of the Teflon piston on the long process, and it is a stable assembly. I do the bend test to see whether it is slipping out, the piston is slipping out of the fenestrum. As you can see that it is nicely fitting there without slipping out. I also do the hook test by lifting up the long process of incus to see whether it is coming out. This will give us an idea whether the length of the piston is adequate. Next, I replace the flap and I do the test to see whether the audibility is good. So I do a whisper test, and then I speak softly and ask the patient to repeat after me, and the patient performed the test well and was able to repeat whatever I said. Next, I try to harvest a bit of fat from the lobule. I infiltrate the ear lobule and make an incision posteriorly, a small nick, separate the subcutaneous tissue, and then try to atraumatically harvest the fat which is present in the lobule. Just a 0.5 to 1 millimeter fat is enough to plug the fenestrum. This will help in keeping the reducing the postoperative perilymph leak, and will also help in stabilizing the medial end of the piston and prevent it from moving all around in the fenestrum. Will seal the leak also very effectively. So next, I again reflect the flap onto the anterior canal wall, and then check whether my piston is in place, and then I place the fat plug onto the fenestrum all around the medial end of the piston so that it does not migrate and it seals off the leak. After that, I replace the flap again and then place gel foam to stabilize it. I put a small cottonoid dressing which I remove after 1 week and ask the patient to take complete bed rest. This is a post-op audiogram. You can see left side there is recovery of the conductive hearing loss. Thank you.